Hello, my name is Dr. Diwan S. Raja. Today I will discuss about the anatomy of the vermiform appendix. The vermiform appendix arises from the cecum as a diverticulum. It is about 2 cm below the ileocecal junction. So, if we go to define vermiform appendix, definition. The vermiform appendix is a worm-like diverticulum that arises from the cecum about 2 cm below the ileocecal opening or valve. So this is the ileum, terminal part of the ileum. This is the cecum. This is the ileocecal opening. Around 2 cm below that, we have a worm-like diverticulum that is called vermiform appendix. This is the vermiform appendix. So it is a diverticulum from the cecum. This is the terminal ileum. This is the cecum. This is the ileum. We got the definition. Now we'll go to the dimensions of the vermiform appendix. This variable dimension. It is about 2 to 20 centimeter in length. On an average, it is about 9 centimeter in length. This is a tubular structure. It is a lumen. Okay. It is about 5 millimeter in width. Okay, the circular part is about 5 millimeter. Okay, we got that. The dimension around 9 centimeter, around 5 centimeter from one side to another side. We got the dimension. Then its position. The position of the base is fixed around 2 centimeter below the ileocecal junction, around 2 centimeter, but the tip is variable. Tip and the part of the appendix other than the base is variable. We have different variation and different type of signs and symptoms in case of appendicitis. Okay, it may be paracolic, retrocecal, then maybe splenic type, maybe pre-ileal or post-ileal type. Okay, it may be pelvic type, maybe promontoric type, promontoric, or it may be subcecal type. Okay, so if you can make this promontoric, then pelvic type, then subcecal type. Okay, so the position of the tip is variable from person to person. So among them, this is most common. Retrocecal type is around 65%. Pelvic type is around 30%. It varies from statistics to another statistics. Most common is retrocecal type, which is behind the cecum. The next common is the pelvic type. Okay, so how can I say this location? So if you draw the cecum and the ileum, okay, if you go through the face of a clock, if you look at the arm of the clock, okay, so if you go to 11 o'clock position here, 11 o'clock position, that is the paracolic position. Paracolic, 11 o'clock position. Suppose this is the base of the appendix, then around 11 o'clock, this is the paracolic position. That is the paracolic position. This is the base. Base means here, and this is the 11 o'clock position. Then we'll go to the retrocolic type. That is around 12 o'clock position. That is 12 o'clock position. Okay, retrocolic. So if we draw that way, okay, it should be more than that. Okay, then this is the retrocolic position, 12 o'clock position. Okay, retrocolic, that is 12 o'clock position. So base is more or less fixed, but the location of the tip is variable depending on the position of the appendix. Sign symptom varies. Okay, retrocolic. Then I'll go to 2 o'clock position, around 2 o'clock position. 2 o'clock position. So if we go like this way, and this is that, okay, 2 o'clock position, it should be like that of here, 2 o'clock position. Okay, that is splenic position. Okay, splenic, and it may be pre-ileal or it may be post-ileal. Pre-ileal or post-ileal, that is behind the ileum, or post-ileal. Okay, we got the splenic position, that is going towards the spleen. Spleen is in the left hypochondriac region. Okay, we got that. And then we have the position that is called promontoric position. Promontoric, that is going towards the sacral promontory. It is around 3 o'clock position. Okay, if we go there, it is around 3 o'clock position. It is promontoric position. Promontory. Then if we go to the pelvic position, Okay, that is promontory, that is 3 or this is 2 o'clock, that is the splenic. Promontory is around 3 o'clock position. Okay, then we go to the pelvic. Pelvic is around 4 o'clock position. 4 o'clock position. Okay, pelvic 4 o'clock position. Okay, so we have one more, that is subcecal, that is 6 o'clock position. Okay, that is pelvic should be 4 o'clock position, where subcecal, okay, this ilium, subcecal, that should go from here, subcecal, that is actually should be like that, subcecal should be like that, that is 6 o'clock position. Okay, subcecal, that is 6 o'clock position. Okay, we got the position of the vermiform appendix. We got that. Now go, where is my vermiform appendix? Location of the vermiform appendix. Location of the appendix. This is located in the right iliac region of the abdomen. Okay, it is located in the right iliac position of the abdomen. We got that. Now go to the appendicular orifice. Appendicular orifice. We told it is around 2 cm below the ileocecal junction. Around 2 cm below the ileocecal junction, here on the posteromedial aspect, and it is guarded by a valve called valve of Garlock. May or may not be the mucosal valve, valve of Garlock. Valve of Garlock. Okay, valve of Garlock. It may be present with mucosal fold, and lumen of the appendix. Lumen of the appendix. This vary depending on the age. In the elderly person, it may be narrowed down, even it may be totally blocked in an elderly person. As a whole, the length of the appendix is longer in children, because children has more lymphoid tissue. There is the reason for that. Okay. If you go to the peritoneal relationships, okay, peritoneal relationship. Okay. The vermiform appendix is suspended by a mesentery called mesentery of the vermiform appendix or mesoappendix. Suspended by the mesoappendix. Okay. The vermiform appendix is suspended by the mesoappendix. Mesoappendix passes behind the ileum and connected to the left layer of the mesentery. Okay. Mesoappendix passes behind the ileum and attached to the left layer of the mesentery. Okay, we got that. So here is the mesoappendix, and appendix is suspended from the mesoappendix that passes behind the ileum and is connected to the left layer of the mesentery. Okay, we got that. And this is the mesentery. For the along the mesentery, the blood vessel goes to the appendix. Blood vessels are passing through the mesentery to the appendix. This is called mesoappendix. So we get here mesoappendix. Mesoappendix that connects the appendix to the left layer of the mesentery. Okay, we got the mesoappendix. Now we'll go to the blood supply. That is very important to us. Blood supply. Blood supply from the appendicular artery. Appendicular artery is a branch of ileocholic artery. Ileocholic artery is a branch of the superior mesenteric artery. So appendicular artery coming out of the ileocholic artery. Ileocholic artery is a branch of the superior mesenteric artery. Superior mesenteric artery is a branch of the aorta. So from aorta, superior mesenteric artery, then ileocholic artery, then appendicular artery. The appendicular artery is also, this is the appendicular artery. If you go here, this is the appendicular artery. This is appendicular artery. And this is a branch of ileocholic artery. This is the ileocholic artery. Okay. This is the ileocholic artery. This is the superior mesenteric artery, SMA, superior mesenteric artery. These are the cecal branches. Anterior cecal, posterior cecal. Our appendicular artery is connected to the, by means of the recurrent branch, to the posterior cecal artery. Okay, it is also anastomosed with the posterior cecal artery by a recurrent branch. We got the blood supply. Okay, so the blood vessel reaches the appendix through the mesoappendix. Okay, we got the blood supply. Now we'll go to the nerve supply. Okay. Nerve supply. Nerve supply via the inferior mesenteric plexus. Inferior mesenteric plexus. It is an internal organ, so nerve supply should be autonomic. Should have sympathetic component, parasympathetic component, sympathetic, pathetic from T10 segment of spinal cord, Parasympathetic is from the vagus nerve, It is from the vagus nerve. We got the nerve supply. Okay. Lymphatic drainage. Lymphatic drainage. What is the lymphatic drainage? Okay. To the ileocholic and appendicular lymph nodes, appendicular lymph nodes. These lymph nodes are present in the Mesoappendix, and this is the larger one. Most of them goes to the ileocholic lymph node. Okay. Lymph nodes. Okay, we got the lymphatic drainage. Now I'll go to the histology of the appendix. Suppose if you have a section of the appendix, what we'll get? We'll get the lumen. Lumen is not very large, narrowed down lumen, lined by columnar epithelium. Columnar epithelium. Then we get the lamina propria. Muscularis mucosa is not very much prominent here. We'll get the submucosa. Okay, we get submucosa. And most important point is that submucosa contain lymphatic nodules. Okay, lymphatic nodules. So lining epithelium is columnar epithelium. Should I have gland? Yes, we have intestinal glands here that go to the mucosa, intestinal gland. Less than that of the large intestine, but we have intestinal gland here also. No villi. Okay, and we'll get the muscle layer, inner circular layer, and outer longitudinal layer. Muscle layer. Okay, inner circular, outer longitudinal layer. Okay, this is a lot of lymphatic nodules. So appendix is also called tonsil of the abdomen. So you can call it tonsil of the abdomen. Okay, we got that. And outside we have the serosa. And certainly we have mesoappendix. It is the serosa, the peritoneum. Okay, serosa. We got the histology of the vermiform appendix. Now we learn some of the embryology. Embryology. This is a midgut derivative. A midgut derivative. Okay, and it is in the right iliac region, that is usual, but it due to male rotation of the intestine in rare occasion, the non-descendant of the colon, it may be under the liver, not in the right iliac region. Rarely. That is possible, but very rare due to lack of descent of the colon of the cecum, and also due to male rotation, we may not get the appendix in exact position or normal position. Okay, we got the embryology of the vermiform appendix. Now we'll learn some of the clinical anatomy, or we can call surgical anatomy. Okay, clinical anatomy or surgical anatomy. It is very important. This is one of the very common cause of acute abdomen in case of adolescent boys and girls, or also the young adults. Very common condition. Okay, appendix may be inflamed. We call it appendicitis. Acute condition characterized by nausea, vomiting, anorexia. And we will have in appendicitis, acute appendicitis, what happened? We'll have pain in the umbilicus, very important, initial pain in the umbilicus. That is a referred pain, because you know that the sympathetic innervation to the vermiform appendix is T10. Also umbilicus dermatome is T10. So that will be a referred pain, because T10 level in the spinal cord, the somatic fiber and autonomic fiber will mingle and it will go to the brain, and brain will interpret pain is coming from the umbilicus. Okay, so pain in the umbilicus, referred pain. This is a referred pain. Okay, so that is important. Also pain will be settled at the McBurney's point. That is very important. McBurney's point. Okay, so pain then goes to the McBurney's point. McBurney's point. What is McBurney's point? McBurney's point is a point, the junction between lateral 1/3 and medial 2/3 of a line from the anterior suprailiac spine to the umbilicus. This is umbilicus. This is the anterior superior iliac spine, and this line is called spino-umbilical line. Okay, spino-umbilical line. Umbilical line. Okay, it is the junction between lateral 1/3 and medial 2/3 of the spino-umbilical line that extend from the anterior suprailiac spine to the umbilicus. This is 1/3, this is 2/3. This is the point. The physician push here by thumb, then patient will have severe pain because it is related to the base of the appendix. This is the base of the appendix. Appendix means vermiform appendix. Okay, we got the clinical anatomy of McBurney's point. This is very important to us. Okay, then what structures are encountered? Also, before going to there, we have to note that there may be pain due to extension of the hip joint, because in case of retrocecal appendix, if it is inflamed, then the psoas fascia will be tense, so there will be pain there. And pain in the right iliac region is due to the parietal peritoneal irritation by the inflamed appendix. Okay, so the appendix is this. It is a lumen. Lumen is very narrow. Okay, so we may have appendicitis due to a ficcolith. Okay, ficcolith is the hard thing from the fecal matter that may impact it here. Okay, or it may be some food particle that may block this part, that may lead to swelling of the appendix. Okay, and we may have blood supply may be blocked to any region. Okay, maybe to thrombosis, that may also cause necrosis to this tissue. So there will be collection of fluid or maybe necrosis. So appendix may be burst out. So we may have burst appendix, that is possible, and that may lead to generalized peritonitis, that is possible. Okay, so surgeon will take care of appendicitis by means of appendectomy or appendicectomy. Both are correct terminology, appendectomy or appendicectomy. Appendectomy or appendicectomy. Same thing, appendicectomy. It is done by the surgeon. What structure a surgeon encounter where he give incision? He may give a longitudinal incision here, but perpendicular incision to the McBurney's point area, or maybe a horizontal incision. It is under the discretion of the surgeon what he likes. What structure a surgeon encountered? Okay, structures encountered in appendectomy or appendicectomy. Appendectomy. Surgeon must open the skin, okay, subcutaneous tissue, aponeurosis of external oblique, then internal oblique muscle, then transversus abdominis, then the transversalis fascia, then the peritoneum. Okay, these structures are encountered like that of the skin, subcutaneous tissue, aponeurosis of external oblique, internal oblique, transversus abdominis, transversalis fascia, peritoneum. Okay, and surgeon split the muscles, and surgeon attempt to protect the iliohypogastric nerve. This is very important. Iliohypogastric nerve that passes between the muscle, that is protected by the surgeon. Okay, iliohypogastric nerve is protected or saved. Okay, then surgeon enters inside the abdomen and surgeon look for the tinea coli. These are the tinea coli. What is tinea coli? That is the longitudinal muscle layer thickening in the colon. We have three tinea coli: tinea libera, tinea aumentalis, okay, tinea mesenterica. So all tinea they start from the base of the appendix of the cecal area, from here. So surgeon can go through, if he has difficulty to identify the appendix, they will follow a tinea coli to go to the base of the appendix. Then he or she can easily pick up the Vermiform appendix. Tinea coli is an important guide to identify. Surgeon then take out the blood vessel, cut and tie it. Okay, take the appendix out and put the stump inside the wall of the cecum and stitch it according to surgeon's technique. They used to do it, and patient will be okay with that. Okay, so that's all about the anatomy of the, and also surgical anatomy or clinical anatomy of the Vermiform appendix. If you like my video, please share the information with your friends. Please support my channel. Please subscribe me. Have a nice day. Bye now.